The topic of neck veins has always fascinated me. The amount of information it gives, the amount of difficulty it creates in the exams. It's very challenging to say the least. So today we'll try to understand a few concepts regarding the neck veins and the jugular veins in particular. So, what is the purpose of recording or looking at the neck veins, recording the jugular venous pressure? So, what information does it give? So, basically, it is done to evaluate the right atrial pressure. Another important information by looking at the neck veins is you get an estimate about the intravascular volume, especially in patients with dyspnea and pedal edema and patients on diuretics. So these are the two important aspects. One is the right atrial pressure and indirectly the right heart failure and the intravascular volume status. These are the two important purposes. So the first thing is you have to locate the neck veins. So how do we do that? You begin by examining the right side of the neck because the right jugular veins have a more direct course to the heart. So they are in a straight line to the heart. The patient is positioned to 30 to 45 degrees to the bed. The patient is asked to turn to the left side so that the sternocleidomastoids are relaxed, the two heads are relaxed and do not obscure the neck veins. It's better to dim the light in the room if at all, if it's possible, to create a sort of contrast and shine a torch towards the patient's ear. So, how does the external jugular vein looks like? It's the most of the time what we see is the external jugular vein. It's seen across the sternocleidomastoid moving towards the mandible. Suppose it's not visible, what do we do? We can give pressure at the base of the neck. You can ask the patient to do Valsalva maneuver or pressure over the abdomen again makes the external jugular vein more visible. So internal jugular vein as such is not seen as such. It's between the two heads of the sternocleidomastoid. As I told, the vein is not seen, but the pulsations of the overlying skin are seen. In difficult cases, it is made visible by lowering or raising the patient to 15 degrees depending upon the situation. When the jugular venous pressure is too much raised, you make the patient more vertical. If the pressure is too low, you make the patient more horizontal so that the vein becomes visible. Exerting pressure over the abdomen again makes the internal jugular vein more visible. So, as per standard books and New England Journal of Medicine, either of the veins can be used for estimating pressure, but for exam purposes, it's better that you say you make use of the internal jugular vein, but the pressure in both the veins is almost the same. So, important question in the exams is how to differentiate a vein from the artery. So, artery is more medial, and the pulsations. The venous pulsations are two negative descents, the X and Y descents. You almost don't see any positive movements in the venous pulsations, but in the case of artery, you see one single outward movement of the artery. So multiple pulsations, especially two negative or inward movements of the vein, distinguishes it from the artery. There are certain maneuvers. Vein is obliterated by pressure at the base of the neck. Artery is very well palpable. You make the patient sit with the back vertical. The level of venous pulsation comes down. Venous pulsations are again lowered during inspiration, and pressure over abdomen raises the level of venous pulsations. This is the position which we utilize to estimate the jugular venous pressure. The back of the patient is at about 45 degrees to the bed. So this is the ideal position to estimate the jugular venous pressure. So estimating the venous pressure. So the internal jugular vein is identified by the two negative descents. You actually don't see the vein as such. It's the skin over the vein which we utilize for estimating the venous pressure. The angle of Lewis is used as the reference point, and the patient's position should be between 30 to 45 degree position. In this position, the angle of Lewis is used as a reference point. It's very important. Measure the upper angle of the pulsation using a simple metric scale. Add 5 to the measurement to express jugular venous pressure in centimeters of water. For example, if the normal measurement is less than 3, then the jugular venous pressure is less than 8 centimeters of water. So this is the visual demonstration. You can see a scale kept vertical at the angle of Lewis. Then the person has used a pointer at the upper level of pulsation. This vertical distance is the JVP. Plus 5, it's expressed as centimeters of water. So here it is about 3.5 centimeters. So with 5, 8.5 centimeters, it's just raised. There's another important bedside test, which is known as the abdominojugular reflux test. Reflux. It's not reflex, it is reflux test. So here, first you identify the upper level of the venous pulsation. Apply gradual, moderate, and sustained pressure in the right hypochondrium or in between the epigastrium and umbilicus for 10 seconds. Again, you get another point. Note the rise in level of pulsations in the neck. So you get 2 points. One before the abdominal pressure and another one after the application of abdominal pressure. So what is positive abdominojugular reflux test? So raise of 4 centimeters between the 2 points for 10 seconds indicates positive jugular reflex. An evidence-based medicine fact which is very attractive and very fascinating. Rise in jugular venous pressure and positive AJR has sensitivity and specificity of 80% of raised right atrial pressure. So this is how you exert pressure over the abdomen. You keep your hand on the right hypochondrium. The pressure should be moderate and sustained. Suppose the patient has a tender hepatomegaly, it's better to use the area between the epigastrium and the umbilicus instead of the right hypochondrium. So here you can see the two reference points what you get in the abdominojugular reflex. One is before abdominal compression, obviously it's lower. The other point is after abdominal compression, obviously it is higher. So the difference between the two, if the difference is more than 4 centimeters of water, then you call it as a positive abdominojugular reflex, and it should be for 10 seconds. For the 10 seconds you put pressure over the abdomen. That is positive abdominojugular reflex. Another important question in the exam, Kussmaul sign. So normally during inspiration the JVP reduces, the jugular venous pressure is reduced. But what happens in Kussmaul sign is there is a paradoxical elevation of jugular venous pressure during inspiration. So what does it indicate? So the differential diagnosis includes constrictive pericarditis, severe right heart failure, pulmonary embolism, right ventricular infarction. So if at all detected, it's quite a useful sign. This is the waveforms of the JVP. As you can see, the EA, C, V waves and the X descent and the Y descent. In clinical practice, 2 points are very important. Only the negative descents are seen in the JVP. It's very difficult to make out the positive waves. So at the beginning of the X descent is the start of systole. Beginning of the Y descent is the start of uh, diastole. These two are the two important facts. So negative deflections or the inward movements are more obvious, and there is you can see both the systole and diastole in the JVP. So A wave corresponds with the atrial contraction and its peak signifies end of atrial systole. So A wave is prominent in complete heart block where the atria contracts against a closed ventricle. A waves are absent in atrial fibrillation where there is no synchronized contraction of the atrium. C wave denotes right ventricular contraction and closure of the tricuspid valve. So C wave is a very small positive deflection, hardly seen clinically. The X descent reflects downward movement of the right atrial floor when the right ventricle contracts. When the right ventricle contracts, it pulls the floor of the right atrium downwards, and that causes the X descent. The V wave corresponds to the venous filling of the right atrium. You can see the engorged right atrium. It's the venous filling which causes the V wave. Y descent signifies 3 points. It signifies the beginning of diastole, opening of the tricuspid valve, and filling of the right ventricle. So this is the importance of the Y descent. So what is the pathological significance or the disease implications of the waveforms? I have already talked about the A wave being absent and A wave being prominent, what are known as the Canon A waves. So prominent attenuation of X descent or even the formation of a CV wave. So the X descent almost becomes absent and there is one big positive wave. It happens with severe tricuspid regurgitation and you get what is known as the wobbling of the earlobe sign. Attenuation or absent Y descent occurs in cardiac tamponade, and prominent Y descent or what is known as the Freidreich sign occurs with constrictive pericarditis. In summary, elevated jugular venous pressure of greater than 9 centimeter water, that is 5 plus whatever the measurement, along with other symptoms, helps in diagnosing right heart failure and suggests pericardial disease. You can't make a diagnosis, but you can suspect pericardial disease. A low JVP of less than 5 centimeters can reflect hypovolemia or use of diuretics. So whatever information I give in these lectures is not a substitute to your clinical reading. It's just a few basic concepts which I try to make it clear. Thank you.